All right, good morning, everyone. So today we will continue with the content on the peripheral vascular disease. And we have, completed and done part of that last week. So we'll continue the last, section of the PVD and PAD. So as just a recap, review some of what we have done or completed last week. The main or the hallmark manifestation of the PAD, peripheral vascular, we said it's vascular, but we focus more on the arterial, and we explain why. So the PAD, we said that the risk factors are tobacco, atherosclerosis, the hypertension, diabetes, high cholesterol, age greater than 60 years old. The main or the most common blood vessels to be affected by the PAD, peripheral arterial disease, artery disease. These are this slide shows the most common locations, anatomic locations of atherosclerotic lesions, atherosclerosis, or the lesions, and that's shown in the yellow, as you see here, colored by, with the yellow color. So that's the most frequent or common lesions. It's called atherosclerotic lesions. Even the aorta will be affected too, and the lower extremities. So the
I don't know if it's just me, but I can't
yeah,
see the slide on my PowerPoint.
you cannot see this. Oh, okay. I'm sorry for these. These are the few things for illustration purposes. I added them last night. So don't worry about these slides. Very few. Like one case study, I have to add a case study, and and a few slides like that one for illustration purposes. Stop sharing. Let's see if I have to go back to the. Can you see the slide now?
Yeah, I can see it.
Yeah.
I don't know if Marivi sees it.
Okay.
I think she meant that we can't see it in our PowerPoint that we printed it out.
I know. Yeah. I did mention that I added the few slides, including this one and the case study, a new case study. Last night, so you'll have it in your old or previous PowerPoint slides. That was just added last night. A case study and the and a few slides for illustration purposes. Sure. Now you can All right, so this is the slide I'm trying to share. I'm not sure why my pointer is not working. Now, can you see the slide?
Yeah.
Okay, so let's see if this is the one. Okay, now it's working. Now, I'm going to flip from one slide to the other. Just make sure that you are following me. Is it changing? Are your screen?
Yeah.
Yeah.
Slide. Okay. Just make sure that because all right. So these are the new slides that I added. Very few, just the case study and 2 or 3, for illustration purposes. Like this one, for example, I found it like very good one from Louis' textbook and shows the common sites for PAD. So now the case study says that the a patient BD is a 62-year-old man reports pain in his lower legs when walking his dog. So the patient, so this is the case study on the PAD, just to apply what we have learned. And it's a continuous, like unfolding kind of scenario. As we cover the treatment and the modalities and surgical therapeutic modalities for for PAD. So pain is relieved with rest, which is consistent with what we have learned, which is the intermittent claudication. And patient has a history of hypertension and hyperlipidemia, and patient smokes 1 pack of cigarettes per day. So as we review, well, what risk factors does the patient have? Things we're going to apply from what we have learned to the case study, because that's the best way to understand the content and how to to apply it, so that good for retention of the content.
Well, the patient smokes a pack of cigarette per day.
Tobacco smoking is one major one.
Hypertension as well.
Hypertension. What else?
And hyperlipidemia.
Hyperlipidemia. Yes. Okay. Hyperlipidemia. And the last one is patients.
Oh, he's old.
Patient's age. So all of these are risk factors, and the more risk factors, the highest as you know, the risk of developing the PAD. Now, with what symptoms does the patient exhibit?
Pain in his lower legs.
Which is the intermittent claudication. Patient experience pain in the lower extremities when they walk, and then as they stop or rest, then that pain will be resolved. So that's consistent with the PAD disease. And as this is a review for your physical assessment course. Make sure that you know where to assess for popliteal, or to assess for the tibialis, for the dorsalis pedis. And so these are, this is a great, slide, so we can remember for were to assess these arteries for perfusion, because it will make a big difference. I mean, we will, cover this, especially for post-op, for two things: for severe PAD, so we can detect the severe ischemia before becoming to a point that there will be necrosis and then amputation, and also post-op to prevent the closure, which is post-graft closure or post-graft occlusion, which is one of the post-op complications. So we need to make sure that you want to know where to apply or where to assess for these peripheral pulses. PP refers to peripheral pulses. So the and the pain, as we know that the patient developed that pain of the lower extremities, that's claudication because of that buildup of the lactic acid from the anaerobic metabolism. In the absence of oxygen and perfusion, cells will lead to anaerobic metabolism for survival, and that results in lactic acid, which is very painful. That's the source of the pain.
Sorry, you said buildup of lactic acid from
Lactic acid, yes. Yeah. And we went over also the signs and symptoms of the reduced blood flow to the limb or to the lower extremity that result in the loss of hair on the lower legs, diminished or absent pedal pulses, pallor of the foot, especially with elevation, hyperemia, redness, when the foot is dependent, the skin is thin and shiny on top. And we talk about the pain at rest as the advanced stage of PAD, or a state or a sign of progressive disease, progressive PAD disease, when the patient experiences the pain at rest, because we'll talk about these stage 1, 2, 3, and 4, right? So you refer to the previous lecture to review the difference between the 4 stages of PAD. Now, let's go back to the previous slide. So when assessing PD, the patient, you find that his feet are pale and cold to touch, and the dorsalis speed is 1+. Posterior tibial also decreased sensation. So there is a pulse. The peripheral pulses are weak, and there is a decreased sensation. So PP. Remember we said the neurovascular assessment. You remember that PP, CMS. PP, which means peripheral pulses. You assess for peripheral pulses, palpation, and sensation. And then the sensor, which is the CMS, which is color, motion, sensation. By doing all these, components of PP, CMS, you have done complete comprehensive neurovascular assessment. And also there is a small area on the lateral side of the left ankle. So, given all these, or the scenario and the resultant manifestations, what are your concerns regarding these assessment findings? The +1 dorsalis and posterior tibial pulses, decreased sensation, small open area in the lateral aspect or side of the left ankle.
What was your question? I'm sorry.
What are your concerns regarding these assessment findings?
The tissues aren't perfusing in his legs properly.
which means that there is a decreased arterial circulation, there is a decreased perfusion to the cells or the lower extremities, and that's an evidence of complication of the arterial ulcer. So there is an arterial ulcer, and that is an evidence of complication to the arterial ulcer.
Also, it
So-
take longer to heal, right?
I'm sorry?
It would also take longer to heal because of the lack of
Right.
perfusion.
Yeah. Healing will be, yes, it will take longer because decreased perfusion. That healing that would be delayed or could lead also some worse scenarios would be the non-healing ulcers. But delayed healing, yes, because of decreased perfusion. So the ischemia, which is in this scenario, which is severe ischemia, we call that CLI, which is critical limb ischemia, which is characterized by chronic ischemic breast pain, which is stage, we said that will be the stage 3, which is the breast pain, lasting more than 2 weeks. We can classify it as CLI, critical limb ischemia. In addition to that, if there is also another characteristic of that would be, or manifestation, non-healing arterial ulcer or gangrene. And that risk would go even higher if the patient is have a history of stroke or diabetic or have a heart failure. So the problem with this prolonged ischemia, it could lead to atrophy of the skin and muscles as well, delayed healing, because you have to connect everything with with the perfusion, significant decline in perfusion and depletion of perfusion, could result also in wound infections, necrosis of the tissues or tissue necrosis. And the most serious would be the non-healing arterial ulcers and gangrene. And that's when patient will be a candidate for amputation. So the diagnostic studies would include Doppler ultrasound, which is like segmental blood pressures recorded. ABI, which is very important. That's the most important aspect of diagnostic studies when it comes to PAD, because you can differentially or you can diagnose PAD just from the ABI. And it's usually done using the handheld Doppler. And you will divide two numbers, the blood pressure, which is from the ankle, over the brachial blood pressure. So ABI ankle blood pressure over brachial blood pressure, then that's the index, ankle brachial index. Now, any number below or less than 0.9, that is diagnostic for PAD. And we have also, we can differentially diagnose based on the exact number, if that's less than 0.9, to be like severe or moderate or minimal. And the lower the number is, the more, more moderate or severe as the PAD.
What did you say the number was again?
Less than 0.9. But we both should be careful with, with diabetes, because patients with diabetes mellitus, they tend to have falsely elevated ABI. So we have to take that in consideration just to make sure that we are doing the, the right calculation. Angiogram, and then we have the MRA and the health and physical assessment. The case study unfolded to say that the angiography reveals nearly completely obstructed vessels in patient's lower extremities. Patient is diagnosed with PAD. So now we have diagnosed. So we're done with diagnoses, and now we're going to move on to treat the problem. What treatment would you anticipate for this patient?
To stop smoking.
Based on, yeah, exactly. So based on the patient's, on this diagnosis and the known risk factors, then the treatment plan would include risk factor modification. So that's a collaborative care for the PAD. And some, textbooks, they refer to it, instead of collaborative, they call it interprofessional care. The kind of the new term replacing the collaborative, now interprofessional care. So the risk management or risk factor modification, which would include all aspects of lifestyle management and modifications, from smoking to hyperlipidemia, like diet for hyperlipidemia, and statins. We can give statins, right? Statin family, remember that from pharm. They can give to lower the hyperlipidemia, control the hypertension and diabetes, maintain blood pressure less than 130/85, and you can do that by medications, but in addition to sodium reduction or reduce sodium in the diet and the DASH diet. Hemoglobin A1C in patients who are diabetic, we should maintain that less than 7. Now, drug therapy. So after that, so that's the first level of management. Then you go up to the drugs, medications. If that doesn't work, or that's there is a need for an additional drug to be added, then you will start with aspirin, Ticlid, Plavix. The most effective drugs. The patient may might be taking two medications, like one antiplatelet and also a medication to treat the intermittent claudication, like Trental or Platal. Pentoxifylline, the pentoxifylline, the Trental, and the silostazole Platal. We don't usually, even call it by the generic name. We call it by the brand name, Trental or Platal. The Trental, just review some, a few things about the Trental and Platal. The Platal, silostazole, it inhibits also the platelet aggregation. So it has that effect that it will inhibit the platelet aggregation, like the antiplatelet agents, like the aspirin, like Ticlid or Plavix. And in addition to that, it will increase vasodilatation. So it dilates the arteries. In addition to it, will prevent blood clots. The Trental, it improves. These are the mechanism of action for these meds. The Trental, it improves the flexibility of the RBCs and the white blood cells. At the same time, also, it will decrease the aggregation or the adhesiveness of the platelets and the blood viscosity. So it will prevent the blood clotting. This is for Trental. Now for Trental, it doesn't work right away, which means that patients should will be taking it for a few weeks until it see any significant changes or improvement. So they have to wait for the effect to be like to occur. So if they kind of ask why I'm being on taking the drug for 2 weeks or or a week or two, and I don't see any any results, that takes longer than that. So that's should be explained to the patient that it takes a few weeks for for the effect to be present. One of the drugs that is so that's for the patient now. The patient is ordered the following drugs: so aspirin, simvastatin, ramipril, which is Altaze, and the pentoxifylline, which is Trental. And it's a good, it's a time to review the the drugs and also the dosages for each drug. The first or so, first of all, not all textbooks they refer to the altase or ramipril or the ACE inhibitors as part of the management for PAD, but it is very effective for PAD. So the ACE inhibitors, they reduce the PAD symptoms. The ramipril altase, one of the best ACE inhibitors to be included in the management of patients with PAD, especially when it's severe, like in this scenario. Because the altase, the ACE inhibitors, they decrease the cardiovascular morbidity. That's kind of evidence-based practice. They decrease cardiovascular morbidity. It will decrease also mortality. It has shown to to decrease these two things, or these two prevalence results, because it decreases the peripheral blood flow. I'm sorry, it increases peripheral blood flow. It will increase the ABI index, which is the ankle brachial index will be increased, and it can increase walking distance in terms of that, you can walk longer distances without experiencing the pain in lower extremities. So we went over the rationale for each of the list of these medications, and now the walking or the exercise. First of all, with the walking is most effective exercise for individuals with claudication. The walking 30 up to 40 or 45 minutes daily for three times a week. That's the optimal outcome, or the optimal goal for for patients with PAD. The given the benefits of the exercise and the on the mobility and the walking, the exercise assists in the also in the build up what is called the collateral circulation. Collateral circulation. It will increase the intensity and the frequency of walking gradually. So as they commit, or they walk 3 times a week, 40 to 30 minutes up to 45 minutes, 3 times a week. That will increase the intensity on the frequency of the walking gradually. So it has shown also that the exercise that or walking will also increase the survival rates. In terms of the lower extremities positioning, and we did compared last time between the arterial, patients with arterial ulcers versus patients with venous ulcers. So here, this is arterial disease. So patients in severe cases with PAD and swelling of the lower extremities, they may sleep with affected leg hanging from the bed, like they are dangling the bed, the feet, because that they feel less pain when they do that positioning. But it's not the same, to be applied or applicable to patients with venous ulcers or venous insufficiency or venous disease, peripheral venous disease. The other aspect or component of the management would be nutritional therapy. We had mentioned that. We said focusing on the cholesterol, low cholesterol diet, the decreased intake of saturated fat and soy products, the weight reduction to maintain the BMI to less than 25. We know that the optimal is 30, or the goal for for all people is 30, but less than 25 will be the best for the patients with PAD. BMI less than 25. The promoting vasodilatation. The application, sometimes patients, they have that knowledge deficit, and they will apply the like a heating pad directly to the skin. No, an assumption that that's going to increase the perfusion. The problem with this is very similar to the concept of applying the heating pads or heat to patients with a peripheral neuropathy and due to diabetes. Same thing here is that because sensation is diminished in the affected extremity, and patient can burn the skin without knowing that they have because they have a limited or decreased sensation. So the sensation is diminished. That's the reason why it's never apply heating pads. The CAM therapy, complementary alternative therapy, you can include the ginkgo biloba. That's effective in increasing walking distance for patients with intermittent claudication. Folate, vitamin B6, the cyanocopylamine, which is vitamin B12, that also is going to lower the homocysteine levels. Remember that homocysteine levels from pathophysiology, the first few slides talk about the risk factors or the pathophysiological changes, and one of the factors that would increase the decrease the perfusion and the atherosclerosis is the high level of homocysteine. So these folate and vitamin B6 or 12, that's going to lower that homocysteine levels. In addition to that, case study unfolding, the patient returns. So before that, patients should that the patients with PAD, they should consult with their health providers before taking any drug, any dietary herbal medication, herbs, supplement, OTC drugs, especially like anticoagulant or I'm sorry, if they are on anticoagulant or they take the NSAIDs, because there is always a room for the potential interactions, drug, herb, or drug, food interaction. So patients should consult with their health providers before taking any type of dietary or herbal supplements, especially if they take NSAIDs or anticoagulant medication. Now, the case study unfolding, and it says that the patient returns for the follow-up in 3 months. Now, blood pressure and the profile, which is lipid levels, are stabilizing, but patient reports the increased leg pain at rest, which is consistent with the pain at rest kind of stage 3. And then the provider determines that it is time to consider the intervention to improve perfusion or to improve circulation to the lower extremity. Now, we have covered the medications or drugs, medications to be included for to increase perfusion and decrease the claudication. The other medications. So, what are other options for this patient at this point? Patient's already taken 4 medications, including Trental, aspirin, Plavix. So the other modalities to treat PAD is the interventional radiologic procedures. The indications is the intermittent claudication symptoms becoming incapacitating, which means that the patient current medical regimen is refractory to treat. I mean, the current medical diagnosis refractory to the patient's treatment plan or therapy. So the patient taking all these meds, but these symptoms are getting worse. So the patient still experienced that pain at rest. Now the treatment for that would be, because we want to prevent the necrosis and prevent the patient from, getting, to lose their limb and, have, undergo the amputation. So the treatment would be, the first one will be the catheter-based procedures, which is done usually in the cardiac catheterization or in the catheterization lab, not in the OR. That's in the cardiac cath lab. And the another one is called the PTA. It's very similar to the balloon when we do the balloon procedure for patients with coronary artery disease. That's very similar, but that's for the lower extremities. It's called percutaneous transluminal balloon angioplasty, and which involves the insertion of the catheter through the femoral artery, and then the catheter will contain a balloon, and the balloon will be inflated to dilate the vessel by cracking that atherosclerosis against the intimal wall of the blood vessel, so we can increase the lumen or the size of the lumen, so we can dilate the blood vessel. So the and some point or some cases you will place a stent. Stent will be placed to hold the artery open to maintain the patency of the, once you do the balloon, you inflate, you dilate the balloon, the blood vessel, and then you want to maintain it, wide open. So you will insert the stent, and the stent will be placed, and then the drug called paclitaxel. That's a drug that's called, because that's the drug on the tip of the stent, or the stent is going to emit and release this drug over time to limit the growth of new tissue in the treated area. Otherwise, there will be like tissues will grow on the stent, and that's going to result in occlusion again. So this drug is going to prevent that or limit the growth of the new tissue in the treated area. Atherectomy, another modality, and it's also using the catheter and the cardiac catheterization or the catheterization lab, but here we can remove the obstructing plaque, so that atheroma can be removed physically, can be shaved off and then removed. There is different ways of doing it. There is like a cutting disc, there is a laser technology, rotablators, rotating diamond tip. There are different catheters that can do the job of removing the atheroma or what is called the atherectomy. Or sometimes we use the cold therapy. It's called cryoplasty, and that's the combining the percutaneous transluminal angioplasty and the cold therapy. So they do the angioplasty, like the balloon dilatation with inflating the balloon, and in addition to also the cold therapy. So that procedure is called cryoplasty. So all of that is under what is called the interventional radiologic procedures. Now we have also some cases, scenarios that you will do the surgical therapy. So the surgical therapy, which is the peripheral artery bypass surgery with the autogenous vein or synthetic graft. So you'll do the grafting to bypass the occlusion using the patient's own blood vessels. One of the surgeons will be harvesting the blood vessel, and then another vascular will be grafting that blood vessel to bypass the occlusion. So the surgical therapies, it can, this is called the arterial revascularization. You're trying to revascularize the area or the tissues that are depleted from perfusion. And as you apply let me just show you here. So this is, the light blue line here, this is the graft. So there is the yellow one here, this is the occlusion. So bypassing the occlusion means that you're going to implant or suture the graft. You can use synthetic, you can use the patient's own blood vessels. You can harvest the blood vessels from like saphenous vein. There's a long vein in the leg that can be used for grafting. There's intramammary vein in the chest. It can be harvested also to be used as for grafting. And the graft will be implanted or sutured proximal to the distal side of to bypass the occlusion, because this is the occluded segment of the blood vessel. So the graft is going to reperfuse. That's why we call the procedure is called revascularization procedure. So the other procedures or modalities is also available. They are also available, like the thrombectomy, endarterectomy, and the amputation. That's the last resort. So the endarterectomy, which is they open the artery and then they remove the plaque. That is an open. It's not like the previous one that's diagnostic, interventional cardiology, or the what is called the interventional radiologic procedures. That's they insert the catheter. That's the only incision the patient would have. But when it comes to endarterectomy, that's an invasive procedure. They have to open physically. They have to like do the incision in the affected artery, and then they have to physically remove it. Remove the plaque or the atherectomy. That's called endarterectomy. Sometimes done also for the carotid artery and around the neck. The amputation that's maybe required if tissue necrosis is extensive. If there's an extensive tissue necrosis, then they have to they are going the last. That will be the last resort, which is the last available option, which is the amputation. Or if the patient, develop the infectious gangrene, osteomyelitis, or if all major arteries in the limb are occluded, there is no way you can do the grafting or you can do the revascularization. Different ways or different methods of revascularization, as you see here, it's different procedures, different veins. Arteries are being used. You can use the aortic, you can use subclavian, you can use other, major large arteries. But the main point here or concept is that we are going to revascularize the artery and bypass the occlusion, so that the distal section or segment of the artery is perfused, so that will maintain the perfusion to the affected area. So the patient undergoes bilateral PTA, percutaneous transluminal angioplasty with stent. So they did place stent. That's called stenting. The nursing diagnosis. So what would be the appropriate nursing diagnosis for this patient? Nursing diagnosis for this patient. Can you give me a few nursing diagnoses that is appropriate for this scenario, for for this patient? Acute pain, that's the first one, right? What about the perfusion?
Wait, I'm confused by the question. Is it before surgery or after surgery you're asking?
No, in general. I'm talking in general. Before and after, anything comes to your mind about the patient who is so just disregard the surgery, because we didn't know if that surgery is effective or not as we speak. So yeah, patient is still so patient is let's say that before, during, post-op, whatever comes to your mind. So we said acute pain. What about the perfusion?
Risk for ineffective tissue perfusion.
Yeah, and then you put in parentheses, specify that ineffective tissue perfusion, which is peripheral.
Yeah, peripheral.
Yeah, peripheral. Yeah, yeah. What about the activity intolerance? Skin integrity, because that's perfusion could result in skin problems, right? So, and ulcers and wounds. So, impaired skin integrity. And if patient is not taking, stop taking the meds, or is not compliant with the regimen, so that's ineffective therapeutic regimen management. So the patient comes to the recovery area after the PTA procedure with stenting, and patient has a bilateral dressing on his groins, and patient is in a supine position. Now, in the acute care, so that's in the recovery, area, which is called the PACU, post anesthesia care unit. We went over this, but we just kind of repeating what we have said, to monitor the following: the skin color and temperature. Remember the CMS, color, motion, sensation, capillary refill, peripheral pulses, the presence of peripheral pulses distal to the surgical site. So make sure that is bypassing that surgical site or distal to the operative site or surgical site, that there is perfusion, which will be evident or exhibited with the presence of peripheral pulses. We should notify the healthcare provider for any changes, because that could, especially post-op, because that surgery was implemented to improve circulation. In addition to the sensation and movement of the leg and the extremity. So after the patient leaves, now patients being discharged home. So now teaching plan, if you're going to implement or to design and develop a teaching plan for the patient regarding immediate care and precautions at home, what would you include? Like things that are essential for patient teaching to be included as as a plan for this patient, so they can manage this disease.
Probably make sure that they take their medications that are prescribed, other immediate. Yeah, I'm not
Right.
sure.
Yeah, they will be on meds, absolutely. So they make sure that taking their medications, especially like they will be on long term. Remember this, they have a stent placed, which means there is high likelihood or there's a high risk for blood clot. That's why they should be on long term antiplatelet or aspirin therapy. Sometimes like in hospitals, they have a protocol of 2 anticoagulants like aspirin and Plavix, clopidogrel and Plavix and aspirin both. So long-term antiplatelet therapy.
Not cross his legs at the knee. You don't want to
Yes,
further damage
Nope.
any tissue.
good.
Wear
So
protective
avoid,
socks and
right.
stockings.
Yes. So avoid knee flex positions. The graduated compression stockings, dead stockings to be placed.
Apply minimum pressure when applying lotions and creams,
Right.
not to prevent more damage.
So foot care is meticulous. Foot care is important, very important. You read a lot about, about the foot care, and the book talks about everything about the, even the type of socks they should, put on, the shoes, comfortable shoes with rounded toes and soft insoles. So they have a lot of, like specifics about these, these things, and I mean, recommendations for patients post-op, or, for, or essential teaching tips for patients to manage their disease post-discharge. Okay, so always remember these 6 Ps when you do the neurovascular assessment, especially post-op, to remember that any sign of the 6 Ps, that is a sign of decreased perfusion. So we kind of summarize that under the PPCMS, and any sign would include, or would be translated as a sign of decreased perfusion: pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, which is decreased poikilothermia, which is decreased, which is the coolness, or cold, sensation, or as you touch the skin, it's cool or cold because of decreased perfusion. We call that poikilothermia. So all these are, so this is the 6 Ps that would indicate the decreased perfusion. So we have a question here. I will volunteers for the question to read out loud, out loud, please.
I'm sorry, can you say the 6 Ps again? I have pain,
Yeah, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, which is decreased warmth, or cold, coolness, or cold, cold skin.
and these are signs of decreased perfusion?
Yeah. Okay, any volunteers?
The nurse teaches a patient with peripheral arterial disease. The nurse determines that further teaching is needed if the patient makes which statement? I would say A, I should not use heating pads to warm my feet.
So it says here, further teaching is needed, which means they are looking for the wrong statement, the incorrect statement. The patient would say something wrong, and then you would correct them.
So then it would be B.
Right. Yeah. A is good. C and D, they're fine, but B is incorrect. So I should cut back on my walks, because patients should be taught to exercise to the point of discomfort. Continue walking until they feel the pain. Then they will stop and rest, and then they will have to, and then they will resume walking until the discomfort reoccurs. That's the best strategy to prevent complications, at least to say. Case study. Other volunteers for the case study? Anyone can read it out loud?
I can read it.
Thank you.
Setting ambulatory care center. Chief complaint, my legs hurt when I walk. Vital signs, respiratory rate, 14 breaths per minute, blood pressure 145/86. Pulse is 70 beats per minute, temperature 99.8. A 74-year-old man comes to your clinic with pain in his left leg that he says he has felt for the past few months. The pain localizes predominantly to the calves and is related to walking, and is relieved when he sits down to rest. The pain is described as soreness and aching, or like being punched. He is able to walk for 3 to 4 blocks before it occurs, and until recently has not been overly limited in his mobility.
So previous medical or past medical history, hypertension, diabetes, tobacco smoking, and patient on metformin, nifedipine. The physical exam showed a S4 gallop and pale pulses, the extremities. Pale pulses are palpable in dorsalis pedis area. So the first question, I believe that we went over this when we discussed the manifestations of PED. So which physical findings should you check for? It will be the loss of hair and sweat glands and legs because of this decreased perfusion, right? Next question is, the best initial step would be,
I think B.
I'm sorry?
Is it B?
B,
Ankle
right, yes.
breaking.
Yeah, ABI, which is the ankle brachial index. And we said that any number less than 0.9 indicates the vascular disease. Because it is premature to go straight to the angiography. Angiography, it's most accurate test, but it's not the one to establish the initial diagnoses for PAD. And Doppler ultrasound, you will use it only when you cannot feel the pulses. So when you're unable to feel the pulses, then you will grab that. Each floor should have that small, device called Doppler ultrasound, and you can you can use it to, to listen for the peripheral pulses. It's not needed if you can feel the pulses. In the upper position, where is the blood pressure is the highest? Upright position. Blood pressure is the highest in the legs, on the arms, when standing, because of the effect of gravity. But with the lying position, blood pressure is more than 10% less in the legs than in the arms, and all that has to do with the gravity. So, which pertains to what is called the ABI. So, as we measure the ABI, we should be careful which positioning we are, patient is assuming. Is it standing, lying, or because that has to do with the ABI results.
So when you do the ABI, do they have to be standing or they have to be sitting, or it just has to be consistent reading?
First of all, consistent first, and then if we prefer that to be lying. Because of that, less confounding factors, which is the gravity, if they are lying.
Okay, I understand.
Yeah. So the scenario unfolds, and patients CBC came back as normal. Patients Chem 7, which is normal, and the Chem 7, which includes chemistry, 7 things, which is the electrolytes, BUN, creatinine, and glucose. So the LDL 145, the EKG showed left ventricular hypertrophy, and the hemoglobin A1C 7%. So now, which blood pressure medication is best for PAD?
Is it the ACE inhibitor?
Right. Yeah. So the ACE inhibitor, and we did, went over this. I mean, we covered this in previous slides, and we explained why the ACE inhibitors are good and the mechanism of action in patients for improving the manifestations in patients with PAD. Now, which medication is most effective in PAD?
Is it B?
Yes, the Plital. Yeah, the Plital. That's the single most effective medication in PAD, and that is used for if you use only one drug or one single indication, that will be the Plital. But we don't use it for other arteries, like you don't use it for the coronary arteries or carotids or for the CVA, like cerebrovascular disease. But for the lower extremities, is very effective. The pentoxifylline, which is the Trental, it's an older medication. It's an older medication for PAD, and the Plital has shown better results and faster results too. So Plital, what should be done about the LDL? Because LDL is higher than 100. So patients should be prescribed drug to lower the hyperlipidemia, which is
B, statin.
statin. Niacin can do, and Zetia can do the job, but they're not effective like statins. Like niacin is not effective as the statins, and niacin is still as the contraindicated in patients with diabetes, because the niacin can increase the glucose and result in hypoglycemia. The Zetia, it will lower the LDL, but has no proven like the mortality benefit. It's not that effective like statins. I have few questions. I'm just going to give you the answer. I don't have to give you time to give you the rationales behind it. What would be the answer for the most effective to stop smoking? You can recall this from psych course. One of the off-labeled uses for one of these drugs.
It's going to be D, bupropion.
Bupropion, yes, Wellbutrin, right? Wellbutrin,
Yeah.
the brand name, yeah. The next question is,
Dr. Mickey, before we move on, for
yes,
the one previous to this one, it was statin, right?
statin, yeah.
And then the other one was A, thrombin inhibition.
Which one?
What's the mechanism
Oh,
of
I'm sorry. For the mechanism of the cholestazol, the
thrombin inhibition?
the Plital, yeah, that should be C.
Okay.
I'm sorry, for this question should be D, phosphodiesterase inhibition. That's the exact mechanism for this drug.
Thank you, Dr. Mickey.
Yeah. Okay, so so which of these is standard preventive measure in this patient? Given the patient's age and diagnoses, it is the abdominal aortic ultrasound. So the rule says that all men who were ever smokers need an ultrasound to exclude aneurysms. especially when it comes to the AAA, the abdominal aortic aneurysm. So I'll give you just the the answers to the questions, because you have to move to go to the VTE and thromboses and how to treat the thromboses. Just give you the answers, and the answer for this will be C. Some of these are very easy, and some of them are more kind of moderately difficult. So this one is C. This one is C. The answer to this one is D, the last one. And again, here also is D, the plighted stockings. The answer to the first one is D, pallor on elevation of limb. And for 2 is refrain from caffeine, C. For 3, very important question, a significant concept behind the question number 3. Make sure that you understand the concept behind it, which is the time it takes. So first of all, the answer to this one is C, that it takes 3 to 4 days for the warfarin sodium Coumadin to start working. The effect of the drug takes about up to 3 days, sometimes even 4 days. So that's the important concept behind it. 4, diabetes mellitus, which is C. So the VTE. So we are done with the TAD, and now we will continue with the arterial, disease, and now it's a venous disease, which is the thromboses that will be that would develop in the venous system, in the veins. It can develop in superficial veins or deep veins. So that's why the outdated term used to say deep vein thromboses, because they found also thromboses or blood clots that would form also in the superficial veins. So that's why the new term now, it is the VTE, which will include both superficial vein thromboses, SVT, and the deep vein thromboses, DVT. So SVT and DVT goes under the VTE, like the umbrella of that will be the VTE. I'm not going to stress, or spend time on the pathophysiology, because you can refer to these slides and just review that from the patho, because that's a very important, concepts or mechanisms, how blood clot would form, and then the risk factors and the pathophysiological mechanisms behind it. So the 3 main, remember that Verco triad, why the blood vessel, the blood thrombus or blood clot thromboses would form, because we have one or more of these 3 factors: blood stagnation, venous stasis, damage to the endothelial lining of the blood vessel, endothelial damage, hypercoagulability of the blood. There is an increased rate of coagulation. So, and under one of each of these factors, you will find a lot of discussion in the pathophysiology why a patient would develop blood clot due to one or more of these factors. So again, there's a lot of information behind it. It's not time to, we don't have enough time to go over the pathophysiology. So I recommend that you understand the pathophysiological basis or foundation from the patho course. So first of all, before we move on to the SVT versus the DVT, the acute and chronic venous disorders include also phlebitis from adult tilt 1, right? So which is the phlebitis, which is the acute inflammation of the walls of the small veins. Mostly, when you insert the catheter in the hand or arm or forearm, the IV catheter is inserted, then phlebitis would result. Manifestations would include pain, tenderness, warmth, erythema, which is redness, swelling, palpable cord, like it's like a cord-like, and it's very similar to SVT, and it's like phlebitis. Then the treatment would be to remove the catheter. And if there's an edema, you elevate the extremity. And for pain and inflammation, you would include the NSAIDs and to add warm, moist heat. So the SVT versus the DVT. So we see that the DVT, the VTE, which is venous thromboembolism, when the blood clot forms in the vein, lower extremities veins, or in any vein, and it detaches, then it becomes an embolus. It travels to the brain, or travels to the heart, or may travel to the lungs. So the major factor in the immobilization to become an embolus, the blood clot has formed, let's say, in lower extremities, and detached and travels through venous system to the right side of the heart or to the lungs circulation, and then it will become like a PE, pulmonary embolism. Now, the major factor in the immobilization of this blood clot is the turbulent blood flow. Too much blood flow, ambulation, activity could result in the dislodgement of and detaching, the dislodgement of this blood clot and to travel through the vascular system. So we have two main types of VTE. The blood clot affecting the superficial veins, or the clot would be present or develop in the deep veins. So in the superficial veins, the patient with SVT, they will have a palpable, firm, subcutaneous cord-like veins, like a red line along the catheter will be seen as a cord-like kind of redness on the skin. So the area is tender, reddened, and the warmth also is present, because that's from the signs of inflammatory response. Leukocytosis, what cells elevates to. And in addition to the extremity edema may not occur. So that's not a must. That's not necessarily that patient with SVT will have edema, but most likely you will see that in a DVT. So the treatment for the SVT, if that's infusion related, patient has the IV catheter and then connected to continuous infusion, could be medications plus IV fluids. So if that's infusion related SVT, immediately you have to remove it. The IV catheter should be removed. And if there's an edema, if edema is present, then elevate the extremity to promote reabsorption of fluid from the interstitial space to the vascular space. We apply warm, moist heat, so that will help relieve the pain and the inflammation. You can add also NSAIDs or topical. There is topical heparin gel can be applied to treat the symptoms. For it takes about max. You can use these like NSAIDs and the topical heparin gel for up to maximum of 2 weeks.
Dr. Mickey, you said
Yes.
If edema is present, we elevate the extremity to help reabsorb fluids into the vascular system, or
Yes. Yes. From interstitial space to the vascular system. Now the VTE, the lower extremities VTE may or may not have edema. Now the Homan sign, because we always hear about the Homan DVT and Homan sign, and the positive Homan sign, which is pain on forced dorsiflexion of the foot when the leg is raised. That's a classic sign, but it's unreliable sign, because we have seen some cases with with DVT, and they have shown like negative sign, and others with but mostly with the DVT, they have shown like negative sign. So it's not, it's unreliable sign with frequent false positives. So if the blood clot involved this is a DVT, involve the inferior vena cava, then the leg will be edematous. So the edema and cyanosis will be present in the lower extremities and the legs. But if the superior vena cava is involved with that blood clot, symptoms will occur like edema and the swelling and cyanosis that will be more in the arms. You'll see it in the neck, back, and face. So that's the IVC versus the SVC. Inferior vena.
Sorry.
I'm sorry?
Can you say it one more time?
Yeah, if the inferior vena cava, IVC, is involved, then the legs may be edematous, swollen, and cyanotic. And if the superior vena cava, SVC, is involved, then the symptoms may occur in the arms, neck, back, and face. Treatment, so diagnosis, before we go to the treatment, diagnosis would be, so first of all, complications, complications will be PE, pulmonary embolism. There is also CVI, which is chronic venous insufficiency. In addition to also another complication which is common is called the PTS, which is post-thrombotic syndrome. Post-thrombotic syndrome, PTS. The PTS, it's prevalent or shown to be present in 8 up to 70% of patients with DVT, or what's called now VTE. It's chronic inflammation and venous hypertension. There is also a damage to the vein walls and valves of the veins, because in veins we have valves. That's why patients with varicose veins, they complain of the lower extremities pain and engorgement of the veins and the stagnation of blood in the lower extremities. That's because of the incompetent valves. So with this PTS, there is a damage to the vein walls and the valves, the venous valves. The persistent venous obstruction. Patient will have pain, aching, fatigue, feel the heaviness and these veins and the lower extremities, swollen sensation, cramping, crampy type of pain, pruritus, which is itchiness, tingling sensations, paresthesia, like numbness, pain with exercise, venous claudication. It's pain due to the venous obstruction. So this is a signs of PTS, and the see a picture, I mean, a figure here, or the picture, or yeah, a picture of the dermatosclerosis, and that's the scarring tissue, or the scar, or the skin on the lower leg becomes scarred, and the leg becomes like a inverted bottle, and this is like a hallmark sign in which there is the skin changes and discoloration of the brownish discoloration of the skin. That's one of the manifestations of the PTS, post thrombotic syndrome. The PTS, the risk factors for the PTS, the post thrombotic syndrome, one of the risk factors would be the age, old age, obesity, patient on anticoagulant therapy like Coumadin, and they have a poor INR control because they have to do the PT-INR frequently. If they have a poor INR control, or they still tobacco users, so they still smoke tobacco, or if they have an increased D dimer, because remember that the D dimer is an indication of the presence of thrombosis and blood clots. Or the patient who had developed a VTE, deep vein thrombosis, they have a persistent leg symptoms for more than 1 month after the VTE. So patient with VTE, deep vein thrombosis, they say that a DVT of right leg, and then the patients continue to complain of the same symptoms for like more than a month. That one of the risk factors also for the PTS. So the diagnostic studies would include the blood testing, like all the coagulation measures like ACT, the APTT, which is activated partial thromboplastin time, INR, international normalized ratio, bleeding time, PT, platelet count, D dimer, fibrin, and we have non-invasive venous diagnoses, diagnostic procedures like Doppler ultrasound. Invasive procedures like the CT angiography or venography, magnetic resonance, the MR venography, CT or MR venography, which is angiography. And then the angiography with contrast. Sometimes you do that, with us. Sometimes do it with. So that with contrast. The treatment or the medications to treat the DVT. So prevention and prophylaxis is very important. Is that you can prevent DVT, prophylaxis, and I'm sure that you have seen this kind of like a protocol being implemented in all healthcare institutions, all hospitals, healthcare, especially hospitals. They have each hospital is supposed to have a protocol how to prevent the DVT and thromboses and the PEs and so that's the VTE prophylaxis. That's the new name for or thrombosis prophylaxis. And each institution, they should have a specific protocol to implement this kind of concept. And because that's developed by the JCO Commission, the Joint Commission, mandated that each hospital and healthcare institution is supposed to have a protocol to show, they have to show their implementation of these protocols, how to prevent the thrombosis and the VTEs in all patients across the board. Any patient comes, so the ambulation, patient who's like, walking, talking, being in the hallway all the time or walking, the ambulatory and good with ambulation, they don't need, that's by itself is the intervention and preventive for the measure for the DVT or for the VTE. Others, bedridden, need heparin, sub-Q, or enoxaparin. So there is specific line. The protocol will include the list of different measures from the lowest to the more aggressive. Heparin, Lovenox, enoxaparin. The least would be the ambulation, right? The one, so that will be the the protocol. So you can refer to your institution's protocol and see what exactly what specifics about that protocol to prevent the blood clotting or the VTE. Second is in patients with or at risk for the VTE. Patients who are at risk, we said, so hospital setting or even home setting, protocols are very important, like early and aggressive mobilization. It's like walking or ambulation. Change position every 2 hours. That's another modality. TID stockings, sequential compression devices, which is the Flutrons. All of these are interventions to prevent blood clots. Medications, we have 4. You can compress these 4 classifications into 3. The first one is the vitamin K antagonist. The second and the third one, thrombin inhibitors, either indirect or direct. And then the last one is the factor XA inhibitors. So in terms that 3 main classifications, because 2 and 3 they pertain to the same thrombin inhibitors, but one is direct, one is indirect. So these are the 4 or 3 main classifications of drugs or medications to prevent blood clots and to prevent the thromboses. They are not thrombolytic, they are anticoagulants. They are going to prevent clot formation. They will prevent they will prevent the new development of any blood clot in the future. The heparin, enoxaparin, all of these anticoagulant medications, they do not have any effect on the already formed blood clot. The thrombolytic medications or thrombolytic agents like TPA, tissue plasminogen activator, that is a thrombolytic that will dissolve the blood clot. The already formed blood clot, the anticoagulants has no effect on it. Our body has a lysis or mechanism to dissolve blood clot, but we don't rely on it when the patient have already formed blood clot, because that takes a while, or our own natural mechanism to dissolve blood clot, which has already been formed. But anticoagulants, they prevent future development of blood clots. Do not dissolve blood clot that has already been formed. The thrombolytic will do that. So this chart is good to to take a look at the chart and see what lab work that should be done for each medication. Once you start the patient on heparin, you continue taking the heparin drip, not the sub-Q. Then IV heparin drip, then you will continue the APTT. Patient on Coumadin, vitamin K antagonist, Coumadin, which is warfarin sodium. Then you continue the TTINR. Enoxaparin, Lovenox, or we don't usually do that, but it's, you can do the ACT if need be. But in general, routinely, we don't do anything for enoxaparin or Lovenox unless it's an emergency or something like, unusual happened from enoxaparin and Lovenox, then you will run or request the ACT. I'm sorry, the anti-factor XA for Lovenox or enoxaparin, anti-factor XA. So I have a list of frequent medications listed as anticoagulant meds that they prevent the thrombosis development, but they do not dissolve the clot. The lysis of the clot begins spontaneously through the body's intrinsic fibrinolytic system. And when you can add a medication also to accelerate that intrinsic fibrinolysis, which is the lysis of the clot, by adding like the TPA, which is a thrombolytic medication. But anticoagulant, they can prevent, but they do not take care of the dissolution or the breakdown of the already formed blood clot. So a lot to say about the Coumadin, the heparin, a lot of discussion about these drugs, but I think we are running out of time. We have only 2 minutes left. So I would just highlight the, you see the difference between A and B, how is, is when the catheter inserted, and we administered the TPA, which is a tissue plasminogen activator through the catheter, which resulted in the dissolution and the breakdown of the blood clot, and that reopened the blood vessel. So the TPA, thrombolytic agents like TPA, urokinase, alteplase, these are like the brand names for the TPA. It directly dissolved the blood clot. Another modality for, which is a surgical option here, thrombectomy, or the insertion of what is called the the vena cava interruption devices. You'll see some of these scenarios like patients with Greenfield catheters, patients with a different type of filters, like called different names of these filters. These filters are device is recommended if the anticoagulant therapy is contraindicated due to the increased risk of bleeding. So patient taking anticoagulant therapy is not working for them because patient is developing bleeding or hemorrhage because of that. So it's not good for them. Then the indication would be to implant or to insert surgically one of these filter devices, and it's and also recommended for acute pulmonary embolism or proximal VTE of the leg with active bleeding, as I said, or anticoagulation is contraindicated or it's ineffective. So these are the scenarios in which that we use these filters. And once you implant this filter, like a device will be implanted to prevent the, it will trap the blood clot. If there's any blood clot, it will be trapped. So it will be inserted percutaneously through the right femoral or right internal jugular veins. And that filter device is, will penetrate the vessel wall. So it's like a trapping kind of device. It will, or a sieve kind of type, sieve type obstruction. It will interrupt the blood clot from traveling to the vital organs. So it will permit filtration of the clot, and it will trap the clot, and so that it will be, become, it will be trapped. So the lysis or the disintegration and the breakdown of the clot over time, it will occur, but it will be trapped in that device. So it will prevent the, the traveling of this, or reaching, this clot to reach the vital organs, and it will trap it so that it will be dissolved with the natural intrinsic cascade of the fibrinolytic mechanism. So I believe this is the answers. I would give you the answers very quick. So the answer to this one is B as in boy. This is a selector, all that applies, so more than one answer. So that will be, the answer is B and D. B and D. Here we, the answer is subcutaneous low molecular weight heparin, D. Answer is A. So that concludes the lecture. Any questions?
What was it for the previous slide?